Great, thank you. Great, thank you. Um, I have nothing to disclose. I just dive right in. And I like to spend some time looking at this graph, blue and yellow. This is a study of testing rates of guideline recommended biomarkers for non-small cell lung carcinoma. And on the left, you see the blue. These are reports of patients getting molecular testing who have been receiving care at academic centers and government institutes. And the y-axis are the genes, EGFR, ALK, etc., down to MET. And on the right, in the yellow, is a similar study, but looking at patients getting molecular testing for non-small cell lung carcinoma in community centers and clinics. Without really reading the numbers, you can see the difference in the height of the bars. So for EGFR, which is a major biomarker for non-small cell, if you are in an academic center, a patient there, you get about 95% chance of getting that tested. If you're a patient in a community center, it's half, about 56%. And then the numbers just keep going for the other markers. So there is a huge difference. And I know we use the word disparity a lot. It's equal difference. So there's a huge difference where you get your care and where you get and how frequently you get tested for these actionable molecular markers. So I had been working in the Deep South in University of South Alabama in Mobile, which is right on the Gulf Coast. And it is really a molecular desert. There are hardly any major medical centers within several hundred miles radius. And the nearest is about 300 miles north of University of Alabama in Birmingham, and then you've got Emory, and you've got in Atlanta. So there's really a huge lack of testing for molecular oncology in this region. And I came to University of South Alabama 4 years ago really with a mission and a passion to really change that landscape. I guess one person at a time. So University of South Alabama Health Networks is the only academic medical center in the Gulf Coast. It has 2 adult hospitals with about 500 combined beds, a children and women hospital, and a small cancer institute. And it's really a catchment of over 500,000 people. So in this lab, we are a small lab, and we've been existing for maybe 2.5 years max. And the goal that I wanted to look at in this short time is first we know that molecular profiling is critical, right, in identifying genomic mutations for targeted personalized therapy. And so our study wanted to look at the outcome of local in-house molecular testing at South Alabama for these underserved populations in this region. So the plan is to look at really 3 simple tests. Single gene assays, PCR-based, qPCR-based. First, BRAF V600 for metastatic melanoma, and we use a commercial Biocartis IDELA platform. Second test, the microsatellite instability, MSI for colorectal, also using the Biocartis platform. Third, quantitative BCR-ABL P210 level for disease monitoring after treatment for CML. Very 3 common, much needed tests. We didn't have that before I came. And we wanted to look at turnaround time, as well as quality of testing as reflected by quantity not sufficient / specimen rejection rates. So in our first gene, the BRAF V600 for metastatic melanoma, in the 1-year, 12-month study, we tested 63 cases, and the percentage are 68% are wild type and 32% mutated with BRAF V600. That corresponds to what we see in the published literature as far as the frequency. What I want to share with you is this graph. It's pretty self-explanatory. For the specimen rejection / QNS, in-house, 0. Maybe 1% if we really get strict without counting. 0. When we used to send these tests out to various labs. So it's not just one lab that I can get, a specific data. But cumulatively, over several reference labs, it's about 12% rejection. Now, we don't know the reason because we don't get that information from the reference lab. But that is a huge change. And look at turnaround time. All clinicians want to know that TAT. For in-house, less than 24 hours. We typically report within 3 days, even though we actually can do it within 24 hours. Great satisfaction from our clinicians and our patients, as compared to more than 7 days for send out. The second test, MSI, similar trend, so I really don't need to speak much. For in-house MSI, 100 cases, most of them are stable. Rejection rate, in-house versus send out, the height of the bar tells the difference. Same thing for turnaround time. We have a 24-hour turnaround time for in-house as compared to historic, more than 7 days when we used to send the same test out. In-house quantitative BCR-ABL P210 assay that we can report both the international scale value, the IS value, as well as the molecular reduction, MR values. We tested about 195 patients over the 12 months. Detected means we do have, measurable levels quantitatively of P210. We have not detectable about 65%, not detectable 30%, and 5% of our patients we received in-house were rejected due to pre-analytical errors, like wrong amount of blood collected, wrong tube, kept in the temperature too long. Okay, so that's in-house. We do have pre-analytical errors. Send out. Historically, we used to send to one lab, and the rejection rate was 20%. A lot of it due to shipment. We had to ship blood, by FedEx, courier, and sometimes there's a delay, there's a flight delay, and so the specimen arrived at the reference lab too late. So we have a 5% in-house rejection as compared to about 20% for send out of fresh blood vials. And the TAT is also, it beats the record of any send out test. So we used to have to wait about 1 to 2 weeks for the result. Now we can report same day. And that's a huge difference to our patients who are actively being monitored for Gleevec effect therapy. So this is not a very long talk, but I just really want to drive home the point that really a small investment, capital and personnel investment in bringing local in-house testing makes a huge difference for our patients. And faster turnaround time, cost effectiveness, right? And better specimen management, reduction of specimen rejection rates are major advantages for having local testing, and dovetail on the previous 2 talks that would enable broader access to precision therapy that is molecular guided to our underserved cancer patients. So I just want to thank you, and if you have any questions, this is my email, and I'm also going to stick around. So thank you for your attention, and we have plenty of time for Q&A. Thank you.
There we go. Hi, Thuy. Great talk, and it really does show that, coming from a larger academic center, seeing how a smaller center works is really important, right? It opens up your eyes. So my only thing is, I just want to know, what do people do for new acute leukemias? Do you have any processes for those, or do those all get sent out?
Yes, unfortunately, they all get sent out. In our institution, we used to have a cytogenetics lab that do a lot of FISH for AML, but operational issues happened, and so we couldn't continue, and so they sent out, and that really created a lot of problem. So kind of went back in time rather than forward, if so to speak. Yeah.
Yeah, I think what you're doing is excellent. So I just want to commend you for that.
Thank you.
Thuy.
Yes.
So this is great work. I guess one of the biggest challenges that you have in that type of setting, but then again, other challenges that we even have at big academic institutions, is the fight that we have to have with our administrators to convince them, when there are real apparent benefits, that it's, that the dollar should be actually be spent for the benefit of the patient rather than the financial, aspects of that medical institution. Because we deal with this all the time, where we can do things and implement these things, and that we have administrators that say, it's, we're sending it out, it's a lot more cost effective. So I can imagine that when you begin at big institutions, and then when you try even bring this in outreach areas, that's such a big battle that you first have to, get over. Any thoughts?
Yeah, I think I was fortunate, and again, I can't speak for just my institution. One of the conditions that we set before we even open the lab, even buying equipment, is we have buy-in from the top down, from the dean, from administration, and because this is state of the art, right? And being the only academic center in that area, it was in a way imperative by reputation and also by mission to have this. Now, these are single tests, commercial, very quick, not that expensive. The question is more expensive assays like next-gen sequencing and even long read and even higher technology. I would envision us facing the same hurdle, but the business strategy that I had was the low-hanging fruit that insurance will cover. So once you prove you can do a small step, then go to the next step and bigger. And I think that was the wise decision, to convince that you can do it. Yes.
Yeah. Hi. So it sounds really very familiar to me because I come from a low resource setting lab. My lab is also small, and we do all these testing at home. My question is, how do you find the QNS in solid tumors? For example, when you do BRAF for melanoma, you just take the sample and put it in the cartridge and perform that. What I observed that when we were doing BioCartis IDELA, we never used the DNA quantity in there or the tumor percentage, but when we moved away from IDELA and moved to another test, we started doing the tumor content and the DNA amount, and we found that some of the negatives on IDELA were positive on other because we did the tumor content and DNA. So when you get negative in the IDELA test, how do you sometimes confirm that it might be the tumor content, less tumor content there?
Yeah, we do look at tumor content, and I would love to answer at length your question offline, but in due respect to the time, maybe we can move to the next session. But I will definitely find you and answer your question offline. Thank you.